So today is my honor to introduce Dr. Lose. Dr. Lose is one of our pediatric endocrinologists who came to us by way of Portland, Oregon last year. He went to medical school, residency, and fellowship out there at the Oregon Health and Science University, where he received numerous awards, including a teaching award for Best Fellow Teacher last year. It's no surprise. And has numerous publications, including research on training dogs to detect hypoglycemia. Impresses me. He's also graciously agreed to do a double lecture today. And for the second half of this talk, he's going to talk about past, present, and future of diabetes. So, Dr. Luse.
Great. Thank you very much. So I'll start off with an apology for actually any third-year medical students. They actually get me for 3 hours today. We just did the resident noon conference lecture last hour, then grand rounds, and then the third-year med student lecture this afternoon at 4:30 if anybody's interested. But I'm very excited to come and talk with you today. Thanks for letting me share something that's really important to me and part of my career, but also part of my life. And so I'm going to give a little bit of a historical perspective, actually, for much of the talk on diabetes and how we got to where we are today, focusing on the discovery of insulin, which I think is actually one of the most impressive and intriguing stories in the history of medicine, leading up to what does diabetes look like today, and then try to shed some light on where might we be headed in the future. Here's my conflict of interest disclosure. I have nothing to disclose. And I won't talk about anything off-label. The outline for the talk, again, past, present, and future. Talking a little bit about the pre-insulin days. And then this very lovely story of the discovery of insulin and how it turned diabetes from a universally fatal disease into a chronic disease. In the present, talking about a very important landmark study called the DCCT and the age of intensive glycemic control, which is really what has been the focus of diabetes management for the last generation. And a little bit looking at the epidemiology and how that's changed over time. In the future, we'll talk about emerging technology, ways to treat diabetes using devices, a look at stem cell research, potential ways to actually go about curing diabetes, and some of the remaining challenges that lie in our future steps. So first, pre-insulin. It was first described in 1500 BC, and actually some of the Egyptian hieroglyphics included some notes about having polyuria. And it wasn't until 250 BC that diabetes was named, and diabetes means to pass through, again referring to polyuria. Diabetes mellitus, if anybody took French or Spanish or one of the other Romance languages in high school, then the word for honey is something similar to miel. And so that's where mellitus comes from. But that wasn't named until the 17th century. And towards the end of the 19th century, that's when it was really understood that if you took out the pancreas of a dog, then it developed these symptoms of diabetes: polyuria, polydipsia, polyphagia, weight loss, and ultimately universal death. In 1910, just over 100 years ago, a compound called insulin was first proposed as being key for glucose metabolism. And without insulin, then glucose metabolism was not normal, resulted in hyperglycemia, which again led to polyuria, polydipsia, weight loss, and death. This is the manual from, I believe, 1917 by a physician named Dr. Jocelyn. And Dr. Jocelyn's a very famous diabetologist. And this is essentially the handbook on how to treat diabetes in 1917, 100 years ago. And it catalogs his experience with 1,300 patients with diabetes And I was able to get it in PDF form. It's about 540 pages. And so I've got some things to share with you from this, just this glimpse at what was diabetes like before insulin was around. This is from the intro to the book, and it didn't reproduce terribly well, but he was really highlighting a starvation diet as the paramount way to treat diabetes. Really, if you stop giving people with diabetes sugar, they won't pee it out. And so he said, if for no other reason, then we need to not waste food. If we prevent the unnecessary overfeeding of people with diabetes, then we will have done a good service to the rest of the world by not stealing food away from the people who don't have diabetes, is essentially what this says. So it was primarily a dietetic intervention. And if someone was diagnosed with diabetes, then they immediately put them, they fasted for 4 days to try to get rid of the glucoseuria. If it resolves, you could add back a little bit of carbohydrate, 0.5 gram per kilo per day. So let's say you had a, 30 kilo 10-year-old who'd probably been peeing a lot, drinking a lot, and losing weight. They would get 15 grams of carbohydrate back, which is about a rectangle and a half of graham cracker. So that's the amount of food that they'd be allowed per day. And they had to avoid all fat until they were tolerating carbs, and then you could add some fat back. You could have some protein, but one day, every week, you had to fast. And if you ever had any sugar in your urine, you immediately needed to fast for a day and then go back to slowly reintroducing carbohydrates. So this was the dietetic intervention for diabetes. There were no medicines. And with this, diabetes was still universally fatal, but you could prolong that course, whether it was a suffering course or a quick course, was really determined by how tightly you stuck to this diet. And if you did not stick to this diet, then it was seen as a moral, personal failure. And it's interesting, they say fasting does not seem like fasting to patients when they receive coffee, tea, cracked cocoa, cocoa shells, and broths, and are given an unlimited supply of water. Warm drinks are preferable. This was kind of a miserable existence. And so if you were diagnosed in 1917, this is what you had to look forward to until ultimately you were still going to die. And if you were the parent of an 8-year-old who was diagnosed, this is what you had to enforce on your 8-year-old until they ultimately died. To check sugar, it was done through urine, and this is a typical way. This is what's called a Benedict's test, and essentially this is what was done until about the late 1970s. You would put a trifle over 1 teaspoonful of urine into a tube and add a little bit of the Benedict solution, and then depending on, you had to heat it to boiling for 3 minutes, allow it to cool, and then depending on the amount of glucose, it would turn a certain color. And then you could tell, was there a lot of glucose, some glucose, or no glucose. And that's about as much as you could do as far as checking your sugar. And most people didn't do this. They just didn't. Sometimes they did. If you wanted to check ketones, you'd use a device like this. That was really more of a research setting. It wasn't really done clinically. Same thing for a CO2 level. And if you were really fancy and you were a patient of Dr. Jocelyn, you might be lucky enough to have a respiratory quotient calculated. And this, if you remember from medical school, it can range between 0.7 up to 1.0, depending on what kind of caloric intake you're having. If you are close to 0.7, it means you're using lipids for fuel. If you're close to 1, it means you're using pure sugar for fuel. And so they could calculate how is this body being run, off of lipids or off of sugar. And so this is what many pediatric wards looked like leading up to the discovery of insulin. Would be big halls of patients who were kind of languishing away, being fed very restrictive diets, usually somewhere between about 400 and 800 calories a day, and they were literally slowly starved to death. So that's why into this setting, the discovery of insulin was, I think, one of the most transformative moments, if a moment can last a year, in the history of medicine. I think it gets close to rivaling the polio vaccine, and it's up there as far as the history of medicine. So the discovery of insulin was, there's kind of like the romanticized story, and I'm going to break it down a little bit and talk about some of the details of it. If you've heard the simple story before, I hope you learned something through this. And there's a terrific book called The Discovery of Insulin that's actually a great read. If you like something kind of medical, but something that's actually really won't put you to sleep, it's a great one. And so this was what patients with diabetes looked like before insulin. And just to let you know where we went after insulin is you could really transform these kids. And it seemed the closest thing to a miracle that I think anybody who dealt with diabetes or had a child with diabetes had ever imagined. And it came in a little vial. And it came from our neighbors up north in Toronto. So this is kind of the classic story. Is a doctor named Dr. Banting and a pre-medical student, Best was his name, and here's their dog Marjorie. And this is how they figured out how to isolate insulin, purify it, and then give it to people. And that's kind of the romantic story. So a little bit about these characters. So in the fall of 1920, Dr. Banting, a 30-year-old surgeon who had essentially been fired from everything he'd ever done, was in Ontario, Canada, and he was being kept awake by worrying about his debts, maybe like some of our residents now, trying to read himself to sleep. And he read an article about the pancreas and the problem of internal secretion is what it was called. He hypothesized that ligating the pancreatic duct might be a way of isolating that internal secretion. This is his diary entry from that day. It's dated either October 30th or 31st, because I think it was right around midnight that he was writing it. And what he wanted to do was ligate the pancreatic duct, wait for the gland to wither away, then take out the degenerated pancreas, isolate it, purify it, and try to take that compound and then inject it into dogs that had no pancreas and save them. And that was his research idea, and it's written down on that page. So he took his idea to his alma mater, the University of Toronto, where he presented it to the world-renowned expert in carbohydrate metabolism, a guy named J.J.R. McCleod. McCleod was skeptical, but agreed to give him a lab and some dogs in the summer of 1921. And it seems, from the story, it seems like, he was always onto it. He knew exactly what he was doing. But really, this was his backup plan. His actual plan was he wanted to be the staff physician on an oil expedition. And he was just waiting for that to come through. And actually, eventually, his application was denied because the oil expedition said, we don't need a staff physician. And so then he said, oh, okay, fine, I guess I'll take you up on that lab this summer. And here's J.J.R. McCleod, the world-renowned carbohydrate metabolism guy. And then there's this dashing Best, who had just was finishing up his senior year of undergraduate at the University of Toronto, and he was the one who got picked by J.J.R. McCleod to accompany Banting into his lab and essentially run the scientific experiments. Banting, again, was a surgeon. He was used to cutting stuff up, but he was not a research scientist. He didn't really know how to do any chemical reactions or anything. So they gave him a 22-year-old university science student who ultimately wanted to be a doctor, but he wasn't quite yet. And so they did their tests that summer of 1921, and at the end, they had some promising results. They said, please, can we continue this research? And they said, okay, fine. Through much of the fall of 1921, they ligated pancreatic ducts of dogs, cats, rabbits, and attempted to isolate pancreatic compounds and then re-inject them into animals to see which ones no longer had glucosuria. They gave him, McCleod gave him much needed advice because neither of them were very skilled in the lab. And a few of the experiments were promising, but the products were impure, and most of the animals actually, rather than curing their glucosuria, they got abscesses, sepsis, and died. So this is from one of their journal entries, actually, of some of their preliminary experiments, where they were saying, hey, this is really promising. I'm able to get either the blood sugar or the urine sugar to start decreasing after I inject them. Here's some more. And they also quickly learned that too much of this pancreatic compound could be a bad thing. And occasionally it would lead to convulsive twitching, salivation and frothing, seizures, and death. So that was the first report of insulin overdose. These characters, James Collip, he's a biochemist at the University of Toronto, and he worked on the purification technique until the compound was felt to be safe and consistent enough to attempt a human trial. They actually tried oral insulin. So they isolated this compound, and they didn't quite realize that it was actually a protein. They didn't realize that if you eat a protein, you just digest it. And so their first trial was oral insulin on the middle character there, Joe Gilchrist, who's actually a physician and classmate of Dr. Banting's. So this guy was 30 years old. He'd been diagnosed in 1917 as an adult. And he'd been on this starvation diet for 4 years. He was still alive. And he was kind of withering away as this, productive doctor who was really most days too weak to actually see patients. But he was desperate, and he heard that Banting was working on something that might help diabetes, and so he volunteered to be the first trial subject. Oral insulin did not work. So ultimately, they were able to purify the compound and gave it to the far character, Leonard Thompson, who was a 14-year-old boy weighing just 29 kilograms. And the first time that they gave it to him, nothing happened. But he got 2 abscesses, one in each buttock. And it's because the compound was not very pure. About 2 weeks later, then Collip had purified a new compound, and they ended up giving it to Thompson again, and it worked. So this is actually the publication from early 1922. He got this here's January, moves into February, and this is the first time he got the impure compound, and his blood sugar didn't do anything. And then this is when he started getting the pure compound. And you can see that there was a dramatic effect. Everybody thought this was pretty incredible. And so they said, how are we going to take this from making enough for one person to making enough for thousands, tens of thousands of people? And there was an absolute desperation on the part of anybody who had diabetes or family who had a child with diabetes. They knew that as soon as word got out that they had something, that it was going to be kind of pandemonium. So in steps Eli Lilly, which at this point was a pharmaceutical company in Indiana, and they didn't have any big blockbuster medicines. Even kind of like the real pharmaceutical industry wasn't around. It was mostly patent medicine and homeopathy. And this was the first time that Lilly hit it big, and it's kind of what sustained their company for decades. This is apparently 2,000 pounds of pig pancreases, and you needed that much to make 8 ounces of insulin, which was about enough to sustain one person with diabetes for 1 year. So for every person with diabetes, they were going to need a pile of pig pancreases that big. So it gives you an idea about what they were up against. So Eli Lilly actually became the biggest processor of pig pancreases, obviously, and within a couple of months turned it into a production line, and they were able to mass produce this. And this was actually kind of one of the early examples of how academic medicine and pharmaceutical company could work together and actually come up with something that really helped people. And they did it really fast. I think it'd be much harder to do that now. There were obviously no IRBs. There was actually not a lot of regulation of the pharmaceutical industry, and not a lot that kept somebody from going from, hey, I got something in the lab, I've tried it on one person, and now I'm going to make enough to treat everybody in the world. And they literally did that in a couple of months. It led Banting and actually McCleod, the research lab supervisor, to get the Nobel Prize in 1923. And Banting shared his prize with Best, and McCleod shared his prize with Collip. And within about a year, then 25,000 patients with diabetes were receiving their regular insulin injections. And so that's the story that I actually wanted to share with you, because I think it really is transformative. And it came out of maybe some of the most humble places, where you've got kind of a failing surgeon who's stacked up with debt, and this not quite medical student. And maybe if it wasn't for them, maybe somebody else would have come along and gotten it too. But it just shows you that don't doubt who you are or where you come from. You can still do big things. So it turned diabetes into a chronic disease. These are some kind of early diabetes supplies. Sometimes there were different concentrations of insulin, and this is actually the brand name. I think I can talk about brands that don't exist anymore, but Lilly's insulin was called Iletin. That wore off and they ended up just calling it insulin. But here's your different concentrations of Iletin. People frequently gave themselves the wrong concentration, and had a lot of issues with insulin overdose. Here's that Benedict's solution where you could check how much sugar was in your urine. Again, most people didn't really do this on a regular basis. Some, if you had means, would be able to check their urine maybe once a day. And then syringes were obviously reusable. Most people carried around a sharpening stone for their needle. So you'd boil your syringe, you'd rub your needle on a sharpening stone, and you'd use the same needle for months or years. Often there was still a pretty restrictive diet. It wasn't go out and eat whatever you want. And I heard a presentation by an 88-year-old woman actually who'd been diagnosed with type 1 diabetes at age 10. And she was up in Canada. She was diagnosed in, I think, the early 30s. And so insulin had been around for 10 years. And I was going, oh, they should have figured all this stuff out. No, she was still sharpening her needle outside. They didn't have running water. So it was really hard to actually sterilize her needles. And every day, for every meal, she was supposed to have essentially a bran muffin, breakfast, lunch, and dinner. And anything outside of that was considered breaking your dietary needs. But they tried to essentially it was like bran and butter. And they just loaded it up. They were probably each 500 calories, and you ate 3 of those a day, and you're supposed to be good. And so she recalled doing that for much of her childhood. So this is the cure that wasn't. Everybody said, wow, this is incredible. All these kids plump right up. And then they realized, wow, okay, so now we've turned something from a universally fatal disease into something that requires daily or even hourly vigilance. And every dose of insulin that you get comes with potential side effects. Often still with a restricted diet, and then they started to see chronic complications. Nobody knew that diabetes and hyperglycemia led to renal failure and blindness and neuropathy, because nobody ever lived that long. But now they did, and so the chronic complications essentially universally happened. And so even though they had insulin and they could kind of check a urine sugar, most people still had very high blood sugars most of the time. And they had chronic complications that set in relatively early. There was often a shortened lifespan. So this came up in the early 1950s. The life expectancy for somebody with type 1 diabetes was somewhere in the early 40s. That is actually still the data that is used by life insurance companies to generate what are called actuarial tables. To say, hey, you're 34 years old and you've got type 1 diabetes, we think you're only going to live 8 more years. So your life insurance is going to be $2,000 a month. Those were my numbers. That's what they told me. And I said, where are you getting that data? Oh, well, we're going off of the actuarial tables. Oh, and I go, how old are those? It was 1954 was that data. So it's changed a bit. Most insurance companies are starting to change a bit, but most of them are still using data from either the late 60s or early 70s. You couldn't check a finger stick blood sugar until like 1978, right? So none of the insulins that anybody uses now even existed in 1978. So it's still an issue. I won't talk anymore about that. It's obviously very personal. Okay. And thankful for an employer that does not use medical conditions as a reason to deny life insurance coverage. So I get the group plan. So here's diabetes, literally from 1923 when insulin became widely available until 1982. There were various insulin concentrations. Eventually it was standardized to what's called U100, meaning 100 units per ml. So if you ever look on a syringe or on a vial of insulin, it should say U100 with a little asterisk there. In the last few years, they've realized that some people need very large insulin doses. Mostly this is type 2 patients, and sometimes 100 units isn't enough. You can't fit it in a syringe, so they've started coming out with U200, U300, U500 insulin. What that has done practically for me is create a lot of insulin overdoses. I think it's extremely dangerous, but it's out there. From 1923 to 1982, there was only bovine and porcine insulin, so beef and pigs. And there was a lot more immunogenicity, so a lot more allergic reactions to the animal insulins, but you had no choice. So literally some people got an allergic reaction every time they gave a dose of insulin. 1982, they came out with human insulins. First time it was able to be generated from E. coli bacteria in a lab, purified, and essentially within about 5 years, then bovine and porcine insulin were essentially gone. Routine home glucose monitoring started in the late 1970s. And in the early 80s, there was this debate. They said, everybody with diabetes always gets complications. Why do we care about blood sugars? If you try to get blood sugars normal, you're just going to get more lows. And we know what lows cause. They cause seizures and sometimes death. And so why are we pushing to try to have blood sugars that are lower? If everybody's going to get complications anyway, why not just run them in the 300s? So that led to this trial called the DCCT. And I'm going to check my time to see how we're doing. Okay, great. So the DCCT was designed to answer this question of, should we really care about blood sugars? And it was one of the largest planned studies and very well designed. It took 1,441 patients with type 1 diabetes, ages 13 to 39, and they gave half of them intensive glucose management, meaning multiple daily injections, insulin pump therapy, and they tried to get their A1C to 7%. They did pretty good. They got to 7.2. The rest, they gave standard of care. And by the way, they all started with an A1C of about 8.5. The rest, they gave standard of care, and they mostly floated around an A1C of 9%. And they just followed them over time. It's very, very hard, very expensive to do this kind of study. And you just wait for complications. That was their outcome. So they waited about 7.5, 8 years on average for patients. Some were in the study for up to 10 years. And then at the end, they said, okay, fine. Now just go back to doing whatever you want to do. And they pretty much all came back to about an A1C of 8%. And they followed them for another 18 years. So all these subjects are still in this study. And really what it allowed us to look at is, what's the effect of an A1C of 7% versus 9% for an average of 7 years? And so the outcomes were, they presented this in 1993. And I've been told that everybody in the room, when this slide went up, gasped. That nobody thought that it was going to be this much, that the effect would be this huge. And they really showed that if you are able to get your A1C down in the 6 to 7 range, you're able to minimize your risk of all these chronic complications to the best of your abilities, and that literally everything else is exponential. it's really hard to explain this chart to a 15-year-old who absolutely feels defeated by an A1C of 12%, and you can't tell them your risk for retinopathy is 18 times greater than if your A1C was 6. Like, that does nothing to empower a teenager. So that's what Dr. Ford and I are up against when we're seeing kids who are really, really struggling with diabetes. But this is the data that drives everything. So after this study was done, everybody was convinced that intensive glucose monitoring was important, intensive glucose control was important. And then following these patients out now 30 years, this idea about metabolic memory came out. That, hey, after 7 years, they all went back to whatever therapy they wanted. But those 7 years set the two groups apart. And literally 30 years later, there's still a difference. And to me, it's an empowering message. These are my patients. These are my 13-year-olds who I say, I do care about your A1C right now because I care about you when you're 40. And what you do today really, really does impact you lifelong. So it ushered in an era of intensive glycemic management, settled the debate about whether intensive glycemic management was worth it. And it's really been what has focused our efforts in diabetes management over the last 25 years. So a little bit on epidemiology, and I want to make sure we get to the future stuff because that's kind of exciting too. In adults, 90% have type 2 diabetes, and only 10% have type 1. In kids, 95% have type 1, but 5% have type 2. In the noon conference lecture I gave just last hour, we talked about how kids often get misdiagnosed when they actually have type 2. And some kids with type 1 get misdiagnosed as well. So just recognizing that the epidemiology is very different in kids and adults. And it may even be that type 2 in kids is a different disease than type 2 in adults. Some similar pathophysiology, but they have very different progressions as far as rates of complications. And then interestingly, and I think what probably a lot of people don't either understand or don't know why it's happening, the incidence, the number of cases each year of type 1 diabetes has doubled in a generation. Now, I don't know if I don't think our gene pool has changed dramatically in a generation. Our environment has probably changed a bit. Rates of obesity actually very, very much mirror these lines. And so there's a thought that obesity is pro-inflammatory, that it sets up something called the Accelerator Hypothesis, that it takes a pancreas that's kind of on overdrive from obesity, and the immune system starts paying more attention to anything that's on overdrive. And that's actually driving increased rates of type 1 diabetes. That's one idea. I don't think anybody knows for sure. This is a slide I made myself. It's got trade names on it, but also the generics next to it. And essentially, it's meant to highlight that for about the first 75 years of diabetes management, we had 4 insulins. And then for the next 20 years of diabetes management, we added 5 more in 20 years. In the last 2 years, we've added an additional 5. So insulin management, and these are rarely used in type 1 anymore. These are all being used. So it's how you treat type 1 is changing. What's also changing is the price of insulin. So this is the price of insulin Lispro when it was first released in 1996. It has not changed at all, and it's now a more than 20-year-old medication. Patent law for insulin is different than all other trademarks and all other patents, and it's not regulated the same way. Essentially, you're not allowed to make a generic insulin. And so the producers of insulin, and insulin Lispro is made by, again, Eli Lilly, they get to essentially set their price. These lines here, this is actually 2 lines. That's the price of insulin Lispro and insulin Aspart. And they go lockstep with each other. It's like the CEO calls the CEO of the other company and says, hey, you want to do a $20 price increase? Sure, okay, great. How about next week? And they just do that all the way up. And so this chart only goes through July of 2016. I added 2017 on there myself. And it's now between $350 and $400 per vial of insulin. Now I'll get into future, looking at emerging technology. A lot of people get very excited about technology, but the head of this research organization called JDRF gave a presentation this last year, and I really liked it. He said, everybody who doesn't have diabetes in the room, stand up. And a bunch of people stand up. And he goes, okay, of those people standing up, everybody who's wearing an insulin pump and a continuous glucose monitor, stay standing up. And everybody sat down. I was like, oh, okay, so we can have the best pump and the best sensor and all the technology, but it's not a cure for diabetes. We can make it more manageable, more livable, more flexible, but you still have diabetes. It's still a chronic disease. It still requires a lot of input on the part of the patient. And so technology will never be a cure. And so that's why I'll talk about technology, and then I'll talk about stem cell research and where that might be a cure. So here's a bunch of devices. Insulin pens up top. These are some insulin pumps, some that do slightly different features. And then at the bottom are continuous glucose monitors, some of them that are getting fancy and go into your phone, some of them that you may not even have to poke your finger anymore. You can just flash this little thing over your arm and it'll tell you what your interstitial glucose is. So, all of these are out except for this one's going to come out in December. So there's just a device explosion. And I think if you're working in medicine from now till whenever, you're going to see more and more devices. Again, these are some of the continuous glucose monitors. They can go from the sensor, which is subcutaneous, stays in for a week at a time, goes to, let's say, a 7th grader's phone. That phone broadcasts it to the cloud. Mom can be watching what the blood sugar is on her phone. And so it's turned our phones into medical devices. You can get it on a watch now. This is kind of a beta version of what is likely to be, well, they're calling it the Bionic pancreas. It's a pump that has both insulin and glucagon in it. This is kind of the first version of it that requires a couple of different sites, a couple of different insulin pumps, one running insulin, one running glucagon, a sensor or two, and then this is what they hope to make on the other side. And the research data on this looks fantastic, but it's still a little ways off. This is data from a hybrid closed loop system where you've got an insulin pump and a continuous glucose monitor that can talk to each other, can make decisions about insulin dosing independently of a human brain. So it looks at what your sensor glucose is. It says, how fast is it changing? Is it going up, going down? Have you eaten anything recently? Do you have insulin on board from 2 hours ago? And how much insulin do I want to give you in the next 5 minutes? And then it gives that dose. And then 5 minutes later, it asks all those questions and does it again. And so literally, as your sensor glucose is doing this, in the background, your insulin delivery is going up and down. It still requires input for carbohydrates that you're eating, how much insulin you're giving just for your meals, but it's doing the background work. And this sounds great. It's been out for about 2 months now. I've got a little bit of personal experience with it, and I would say about 80% of the time it works great. And about 20% of the time I want to rip the thing off and send it back to the company because I hate it. We'll see. It's, I'm hoping that it will drive other companies to continue to improve, but it's kind of the top of the line technology that you'll probably start seeing more and more of. And then there's some people who say, forget it, I can do this myself in my garage. And there's literally about 1,500 to 2,000 people who have made their own artificial pancreas. And so this is from a website that will teach you how to do it. And you can use an insulin pump, and you get a Pebble watch with this program on it called Night Scout that was written by a Bay Area entrepreneur. You get a continuous glucose monitor, you get a controller module, you get something that can broadcast the signal, and you get an external battery, and you strap all this onto your 4-year-old daughter. But what's really interesting, so every Wednesday night, they all meet online and have an open discussion, and all these 1,500 to 2,000 people who are experimenting on themselves and their kids say, hey, I tried this, I worked with this algorithm, this worked, this didn't, try this. And literally, it's an iterative process. And so whereas a pharmaceutical company or a device company has to work through IRBs and FDAs, and 3 years from now they'll come out with a new product, the parents are coming out with new things every week. And it's actually driving the device companies to move faster, be quicker, incorporate a lot of those features because that's what people want. So I'm thankful for those kind of crazy people who are willing to turn themselves into guinea pigs. And they've got the time and the knowledge to be able to do it. But it feels a little bit like when insulin was about to come out or had just come out and people are going, we got to get this stuff right now. Okay, so here's stem cell research and a little bit more. I'll go a little bit quickly through this to save some time, but the Edmonton Protocol, again, Canada, they came out with sort of the first stem cell solution to diabetes. And so essentially they took pancreatic islets from cadavers, they isolated them, and then they squirted them into the portal vein of somebody with diabetes. And they realized, well, that's not going to work. We've got to give them some immune suppressants, so they did. And it kind of worked. So in 2000, they published this. It's been around 17 years now. 7 subjects were insulin-free after 12 months. They were on a bunch of immunosuppressants and had to get levels checked, and they had to have side effects and all this stuff, but they were off of insulin. So it was kind of like a proof of concept. People kept improving on this. As of 2010, there had been 571 people who'd had a procedure similar to this, but it didn't work all the time. 60% ever came off of insulin for more than 2 weeks. And almost everybody was back on insulin within 5 years. So again, not quite a cure, but really interesting. It's limited mostly by lack of donor organs. It's really challenging to get enough donor pancreases. You can't get them from pigs. You can't get 2,000 pounds of pig pancreas. And so they need actually multiple cadaveric donors to isolate enough beta cells to give to one person with diabetes. And then the medication side effects are huge. So it's led to multiple different ways that people are trying to address this with cell replacement and immune tolerance. So there's some thoughts about, oh, let's use the omentum. It's kind of like this place in your body that the immune system has to put up with a lot anyway. Like you eat food and you have to not be able to have a reaction to it. And so there's stuff about the GI system that I don't understand. Maybe Dr. Malkani can say something about it, but it's, they chose the omentum as being, hey, there's this little fatty apron and nobody cares about it, but maybe we can cure diabetes. So they layer down donor islets, put autologous plasma on top, and then on top they put clinical grade thrombin, and it really minimizes the inflammatory response. And they've had some pretty interesting data out of that. Encapsulated donor islets, so that's the picture down here. There's a company in California that essentially has made a nanoparticle mesh, a little envelope to package this stuff inside, seal it up, and then implant it. And it's the aperture, the holes in this nanoparticle mesh are small enough that insulin can get out, but immune cells can't get in. And that's, they've got several clinical trials going. They're probably not going to be done for a couple, 2, 3, 4 years. But they've got potentially enough data there. They've got about 50 human subjects that they'll have data on. And it might be enough that the FDA might even grant them like, hey, yeah, sure, you can do this. But in mice, it's beautiful. I've seen the data, and you put these in mice, and they have normal blood sugar. And they don't need any drugs or anything for immune tolerance. If you're already going to get a kidney transplant for some reason, and you have diabetes, then you might just do a kidney pancreas transplant together. They actually share some blood supply, so it's actually technically fairly straightforward to do. And they have to be on immune suppression anyway for their kidney, so you might be able to sneak some pancreas in there too. I saw that for the first time as a 4th-year med student, and I was like, whoa, this is awesome. Total pancreatectomy, this is for people with chronic pancreatitis who essentially they are auto-digesting their own pancreas because of their pancreatitis over and over again. So if you can take that pancreas out, great, now they don't have pancreatitis, but if you can save the pancreatic islets, you can put them back in. And they don't have the inflammatory response, so then you actually cure your diabetes, which is kind of cool. This is something called T-Rex, is looking at the T regulatory cells. Immune therapy within the first 100 days after diagnosis with type 1 diabetes. And they might be able to teach these T regulatory cells to be self-tolerant to your own pancreatic beta cells. so that you don't continue to lose beta cells. Because when you get diagnosed, you probably still have like 15–20% of your beta cell mass. And if you could save that, great. It would make diabetes management much easier. There's somebody who's using a BCG vaccine and thinks that you can cure diabetes with it. They did it in mice. It looks like it works pretty well. The human trials are in the second year of a 5-year study. Most people think that the principal investigator is a total nutcase, but that's probably what they thought about Banting and Best until they hit it. So I'm willing, I mean, if she's a nutcase until she's a genius, and then it'll be great. So we'll see where that goes. And then there's kind of a whole idea of, can you just do a cheek swab, de-differentiate those cells into stem cells, grow them up into pancreatic islets. They're from your own cells, so there shouldn't be an immune response. And can you just take an injection of that once a month? And who cares if it gets killed off, because you can just get another injection of your own cells. So there's some ideas there that are going on. Last, the remaining challenges. This is a chart from a study called the Type 1 Diabetes Exchange. It's about 28,000 people with type 1 diabetes. Essentially, it's supposed to be a snapshot of what diabetes looks like in America. And they asked, what's your A1C? So on the bottom is age. On the y-axis is your A1C. And I really like this because it highlights where I work, which is not just the peak, but it's also what's leading to the peak. And it tells me that when I've got a 12-year-old who's just starting to struggle, is there anything I can do to prevent them from going higher? You'll also notice that where that peak is, 9%. That's the standard of care group in the DCCT versus 7% or 7.5% in the adults. So if we could somehow avoid those 7 years of an A1C of 9%, you'd have a really dramatic effect with your metabolic memory. So that's why I come to work energized, because I know I can make a difference. So here we are 96 years after insulin is discovered, turning it into a chronic disease, one requiring kind of constant vigilance of blood sugar. I wrote all this out because I wanted to make sure I got it. Punctuated by blood sugar checks, carb counting, insulin doses, hypoglycemia, and ketones. We added insulin pens, insulin pumps, CGMs to make it easier. We got tubes attached to our bodies, middle of the night beeping, device malfunctions. We connect our phones and our data can go to the cloud. We get parents watching from home or work their child's blood sugar dropping during PE class at school. Yes, kids with diabetes should expect to live long and healthy lives, but we have no cure. You know, it's 96 years and we're still using insulin. And so I'm waiting for the day when I get that phone call that says they got it. And you're out of a job. And that'll be a good day. Thanks. Yeah.
I have also personal interest in diabetes. Before I try to keep up with things, but excellent talk. I am alumni from the University of Texas, San Antonio. I do not know if you are familiar with what they are doing or not. I'd be happy to share what I got from them 4 months ago. It's very, very, very exciting. They have some gene therapy. They're trying to alter the non-beta cells in the pancreas to beta cells. And it seems like it worked in mice, and now they are doing it in humans. And hopefully, they say in 3 years, they'll be able to do it in humans.
Yeah.
So I really like your talk, and I like your to have your email for my personal interest to share it with you.
Sure. Thanks very much. Yeah, there's a lot of exciting research that's going on. I'm not supposed to say this, but type 1 diabetes actually probably gets more research dollars than it maybe deserves. I don't know if that's the right word, but having a kid who has to take shots makes for a really good poster child for we need to be working hard and throwing money at this. And so they're actually, I'm thankful for that because there is a lot of research, there's a lot of advocacy going on. And I love that we're coming at it from 20 different angles because somebody will hit it and that'll be great. Yeah, Dr. Wood.
Thank you for an excellent talk. Can you speak to potential interventions to reduce that hump in the adolescent years, particularly interdisciplinary?
Yeah, absolutely. So when I see somebody with diabetes, I'm their endocrinologist, but I'm also their dietitian and their social worker and their psychologist and their behavioral therapist and their parent sometimes. And a disease that touches every part of your life, you can't fix with just insulin. So in larger centers, there often are other providers with specialized skills to address a lot of the things that cannot be fixed with more insulin. If you're not taking your insulin, then increasing your doses doesn't do anything. If you don't know where you're going to sleep tonight because your landlord just threw you out, you're not really worried about refilling your insulin that's going to run out in 3 days, because that's 3 days from now. So there's socioeconomic factors that play a huge role. There's psychosocial factors. There's mental health issues. There's access to care issues. I think just within the last week, we have a patient who we don't really know how they're going to get any of their medicines because they're undocumented, they have no insurance, but they have diabetes. They didn't choose it, but they've got it. And so what are we going to do? We're going to slide them insulin under the table and tell them to not tell anybody. And so we're dealing with so many things that cannot be fixed with an insulin pump or a CGM. Those are probably the hardest things to change, and they're the things that probably get ignored the most. And I don't know what the best answer is, but I've seen a couple of models that work pretty well. We're in the process here of trying to work on kind of like a multidisciplinary chronic care team model to address kids who have chronic health conditions. And really, I don't know if the answer is another nurse to call them again to remind them to take their insulin. I personally don't think that's very helpful. I worked in a place where there's a program that's much more of a surrogate parent program, where it's like, if you and your crazy life and your crazy parents can't figure out how to get your insulin in, maybe somebody can walk alongside you and teach you how to be a responsible adult. And do that through having somebody who can be a parent for you. But that's an extremely expensive program. It's hard to do. It's probably cheaper in the long term, but it's really hard to get buy-in from folks to go for it. Yeah?
Dr. Liz, have you met Brittany Lewis yet? I don't think you all have.
Hey, Brittany.
Dr. Ford. I just wanted to take this opportunity to introduce her. So she is a nurse consultant with Family Health and Wellness in the Regional Health Office, and is the person that we are lucky to have for this new care coordination program that you mentioned, along with a team that's still to be hired for including a central worker. So I just wanted to introduce everybody to Brittany, and you'll be seeing more of her. She's just gotten kind of credentialed, and we have 4 days on the calendar here at Niswonger in late December, right before Christmas, to get this program sorted out and up and running.
Yeah,
And my hope is that we will be able to build a program with the resources that we have that will really help some of your patients.
The goal is it's got to benefit the kids. I don't want to do it to benefit ourselves, to make ourselves feel better that we're doing something. It's got to work. So the outcomes are going to be really important in anything, whether you call it a program or whatever. I don't think 14-year-olds want to sign up to be in a program, but they might go for someone who's willing to walk alongside them and be non-judgmental in diabetes management and help build them up and tell them that, hey, they're a valuable person and we can do this together. So it's a complicated model to try to make work. It's a tall order, but I'm really thankful because I'll tell you, if I've got 20, 30 minutes with somebody and I'm saying, this is what I think you should do, good luck for the next 3 or 4 months. If I don't think it's going to happen, I'm totally disempowered to actually think that I can affect change in a teenager who's burnt out on diabetes. But if I've got somebody who can work with them on a daily basis, it's a huge, huge impact.
How many patients would you say you all have that are in that age range that
yeah.
have social issues interfering with care?
Yeah, I mean, this is a guess, but it's an educated guess. So we've got about 400 kids with type 1 diabetes. You know, probably half of those are little kids, half of them are teenagers. Yeah. I'd say every teenager struggles with diabetes. It's whether you're struggling well with it or struggling not well with it. And I would go as far as saying half of the teenagers are struggling not well with it and could benefit from something more that I can't offer. Right. I don't know if all of them need to be in, you know, a highly intensive program, but I know that Dr. Ford and I could each name, you know, 10 or maybe 15 of our own patients that if there was the support structure for that, we would say, yep, this one, this one, this one, this one, this one, and this one. And it's because it's those 10 patients who are keeping us up in the middle of the night going, how am I going to help this kid?
Okay.
Great. Thanks so much. I really appreciate it.
Thank you.